Perfect. Well, hello, everyone. Thank you for joining us today. I'm Manuel, and I am the Patient Family Donor Partnerships and Education Manager with CDTRP. Again, thank you for joining us for what's going to be a fantastic presentation on virtual research ethics, ethical issues conducting research in the COVID-19 pandemic. Which I'm sure most of you already know, we have a fantastic speaker lined up for today. But before I introduce him, just a couple of housekeeping rules. So during the presentation, we ask that you turn your mics and cameras off. Following the presentation, we will have time for Q&A, and at that point, we do invite you to turn back your cameras and mics on, and then ask our presenter the questions directly. Just to note that this portion is being recorded right now, but once we get into the Q&A, we will stop recording at that point. Of course, because we're recording it, we are going to upload this to CDTRP's webpage. So at that point, if you guys want to go back and reference the presentation or share it amongst your networks, I certainly encourage you to do so. And now I want to actually invite Anne Halpin, one of our awesome trainees, to introduce our speaker. So Anne, I will throw it to you.
Okay, thank you so much. It's my honor to introduce our speaker today, Dr. Charles Weijer, who is a professor of medicine, epidemiology, and biostatistics and philosophy at Western University in London, Canada. Charles is an internationally recognized expert in research ethics, and his publications on the duty of care in clinical research, the ethical analysis of study benefits and harms, and empowering communities in research have been broadly influential. From 2008 to 2013, Charles co-led a collaboration that produced the first international ethics guidelines for cluster randomized trials. And from 2014 to 2018, he collaborated with Dr. Adrian Owen on a project exploring the ethics of functional neuroimaging after severe brain injury. And his current work explores ethics of research involving imminently dying patients and ethical issues in organ donation, including the use of normothermic regional perfusion. He held the Canada Research Chair in Bioethics from 2005 to 2019, and in 2014 he received Western Helmus Prize for Achievement in Research, and in 2016 he was elected to the Royal Society of Canada. So thank you so much for being with us today.
Well, thanks so much, Anne, and thanks Manuel. It's a real pleasure to be here today. So let me just share my slides. Can you see them all right?
Yes, perfect.
Okay, great. Well, thank you. As you've heard, what I'm going to talk about today are some of the ethical issues in conducting non-COVID-19 research during the pandemic. So the world, unfortunately, has been under attack by the novel coronavirus SARS-CoV-2 since the first reported case in December of 2019. By any metric, the world has been devastated over that period of time. According to the World Health Organization, there have been 140 million confirmed cases of COVID-19 and 3 million deaths. Sadly, both numbers are known to be underestimates of the true impact of the virus. The impact of the pandemic on non-COVID research has been substantial. Of trials registered in the clinicaltrials.gov database, over 2,000 trials have been terminated, suspended, or withdrawn, citing the COVID-19 pandemic between December of 2019 and January of this year. And that's directly affected 129,000 participants in these trials and interrupted plans to recruit over 4 million other people into these trials. So it's clear that virtually every ongoing non-COVID-19 study involving participants has been impacted in one way or another by the pandemic. So for the trials that have persisted, what challenges have investigators faced? Well, broadly, I see 5 main issues: recruitment and consent, communication with site staff, intervention delivery, data collection, and restarting paused trials. So I'm going to say a little bit more in this talk about three of these challenges, specifically challenges related to recruitment and consent, intervention delivery, and data collection. But before I do a deeper dive on those issues, what I'd like to do is talk for just a few minutes about sort of the big picture ethical issues that I see in terms of a shift towards more virtual research conducted during the pandemic. So there are broadly, I think, five ethical issues here. The first is safety. Have all needed steps been taken to protect participant safety, including protections for research-related clinic appointments or face-to-face study interactions? Social value. What is the impact on the study's ability to answer the scientific question and generate social value? Third, have benefits and harms of study participation been substantially altered, and do they remain in reasonable relation? Fourth, with changes to remote recruitment, intervention delivery, and data collection, are adequate steps in place to protect the privacy and confidentiality of the participant? And fifth, and finally, will people, including those from minority communities and those who lack internet access, have equitable access to the study? Changes made to ongoing studies may require that additional steps are taken. Commonly, changes to ongoing studies, particularly as they impact participant safety, will require Research Ethics Board review. Particularly, any changes to study interventions, data collection, or informed consent procedures will, of course, require REB review. However, one of the challenges here is that timely REB review may be impacted due to large increases in REB workloads due to increasing numbers of COVID-19 studies and the switch to virtual meetings. A key question for the Research Ethics Board is whether informed consent is required for changes that have been made to ongoing studies. Two circumstances may drive the need for informed consent. First, when there's been a substantial change to the benefits and harms of study participation. And second, when there have been substantial changes to the study intervention itself or data collection procedures. Finally, when major unplanned changes have been made to a study, these changes must be clearly reported in the study protocol and the final report. Reporting guidelines on this situation would really help guide researchers and journal editors. And I'm happy to say that there's a group led out of Toronto, including An Wen Chan, Aaron Orkin, Peter Gill, and Peter Uni, and they're leading new reporting guidelines for major unplanned changes to randomized controlled trials. So we're certainly looking forward to the publication of that new guidance. Now that I've sort of discussed the ethical issues in broad outline and some of the impacts that might have on REB review, informed consent, and the reporting of research, I'd like to now do a deeper dive on the three issues that I mentioned. So let's start here with recruitment and consent. So we're all familiar with the requirements of written informed consent in research. And when studies continue to see people in person, such consent may continue to be executed in person, of course. But there's one of the major changes that's occurred during the pandemic has been a shift towards the use of virtual or remote consent. So what does that mean? What does virtual consent mean? Well, I mean, it's pretty much what you'd expect. It refers to the process of conducting the consent discussion and obtaining consent when the research team and the prospective participant or their substitute decision maker are not physically in the same room. What are the ethical issues raised by virtual consent? Well, of course, participant autonomy is a central ethical issue, but I think it's really important to remember that broader ethical issues are raised by virtual consent. While they have advantages, online materials may be difficult for some to access and use. Equitable access to study participation may be threatened when people lack access to the internet or they just simply don't have a smartphone. And so one of the key takeaways here is that researchers and REBs must be really mindful of participants who may not have fair access to study participation as a result. And particularly when study participation offers the prospect of direct benefit. So not only in those cases, but I think there's a special importance when there's the prospect of direct benefit. Steps ought to be taken to mitigate these inequities. So this could involve something as simple as just conducting the consent procedure using regular mail and a telephone. In other cases, though, it may mean that researchers need to ensure that the participant has a family member present to assist with technology or perhaps language differences that exist. In yet other cases, it may involve providing people in the study with a smartphone or a tablet for the duration of their participation. So let's talk about each of the steps now that are involved in the virtual consent process. So this is the first page of the letter of information template for my home institution. You'll note if you look at the bottom there are 29 pages to this document. The letter of information, as with any other kind of research, needs to be shared with the prospective research participant. Of course, it can just be mailed to people, but it can be provided by email or through an e-consent platform. And when the research involves only a minimal risk questionnaire, survey, or interview, the letter of information can be abbreviated. The second step in the consent process is the consent discussion. And so for the consent discussion, either phone or video conference can be used in virtual consent. But video conference is generally preferred as it's more like the face-to-face encounter. Institutions generally restrict video conferencing to approved platforms that meet their own particular security and confidentiality requirements. During the discussion, prospective participants should have the letter of information handy for their reference. Of course, the study team is going to review the information for the prospective participant, give them the opportunity to ask questions, and have a bit of an exchange about what participating in the study might mean for the prospective participant. Importantly, this exchange allows the researcher to assess the prospective participant's understanding of the consent materials. We all know that consent is a process, it's not a one-off, and that means there needs to be a plan for participant communication throughout the study. And again, for research involving only a questionnaire or a survey, this requirement of a virtual consent discussion may be waived. The third step is sort of how do we document informed consent? And I have to say that of all of the aspects of virtual consent, I think this one might have been discussed more than any other. Of course, signed consent forms can just be mailed back to researchers, but what other ways might satisfy requirements for documenting consent? Well, signed forms can also just be photographed or scanned and email to researchers. There are some really great free apps now that for one's smartphone that work very, very well at scanning documents and turning them into PDF files. There are other options, of course. There's electronic signature software and e-consent platforms that allow forms to be signed online. As with any other type of research, participants should have a copy of the signed form. And the requirement for written documentation may be waived for certain cases, again, particularly minimal risk kind of questionnaires, surveys, and interviews. So let's shift gears a bit here now and talk about intervention delivery. That's another one of the challenges that research studies conducted during the pandemic are facing. With regard to study interventions, I think it's fair to say that the key ethical consideration is whether the study intervention can be delivered to the participant safely. In some cases, this has just meant stopping intervention delivery, either pausing the study or halting the study permanently. In yet other cases, a safer means of delivering the study intervention has been adopted. So let's talk about those two different cases. Interventions that must be delivered in person have commonly been put on hold for at least periods of time during the pandemic, if not for the entirety of the pandemic. In some cases, that has led to study termination. In other cases, interventions to be delivered alongside clinical practice, such as an intervention to be given, say, after an elective surgical procedure, those have been put on hold as elective surgery has been restricted during periods of the pandemic. When stopping an intervention, it is of central importance to ensure that the participant has continued access to needed care. Plans should be in place to ensure that the patient is transitioned to a suitable health provider to meet their needs. In yet other cases, participant safety may be best promoted by adapting the intervention. So commonly here, it's intervention delivery that's adapted. So rather than, for instance, coming to the clinic for medication, medication is now being delivered to patients' homes. And that has a lot of advantages. It allows the study to continue, but equally importantly, it allows for continued access to study medication for participants. In other cases, the intervention itself is being transitioned to virtual delivery. So psychological counseling and behavioral interventions have shifted to online delivery. While this allows the study to continue, and that's a good thing, this shift towards virtual delivery of the study intervention raises issues of confidentiality and, equally importantly, issues of equitable access to the intervention, similar to those that we discussed a moment ago for virtual consent. So now let's shift and talk about challenges for data collection. I think we're seeing a wide array of impacts on data collection in studies conducted during the pandemic. For participants who are already recruited or who are in a follow-up phase in a study, data collection has proceeded unimpeded when the study is only using routinely collected data. In other cases, to minimize the need for participants coming to hospitals or clinics, schedules for blood draws and collection for other biological samples have either been paused or adjusted. In some cases, as with, say, saliva samples, it's been possible to send testing kits to participants directly in their homes, have them sort of perform the test, collect the saliva, and mail it back to researchers. In other cases, questionnaires that were to be completed in person are now done over the telephone or online. And there has been a large shift towards self-reported data, including data recorded online, through apps on smartphones, and through wearable devices like Fitbits. So let me say a little bit more about the impact of pandemic-related changes on studies involving interviews and focus groups. And I do that just because it involves some of the studies that I'm involved with. And I'm drawing here specifically on our Ethics of Pragmatic Trials research group's experience interviewing hemodialysis recipients. And this work is led by Dr. Stuart Nichols at the Ottawa Hospital Research Institute. So in our study, prior to the pandemic, all focus groups were conducted in person, but interviews were often conducted on the telephone. Not always, but that was just commonly more convenient for the research participant. Conducting interviews using video conference has led, maybe a little bit surprisingly for us, to the perception that there are actually some advantages to the use of video conferencing over interviewing people on the telephone. Our perception has been that there's an advantage to being able to see people's facial expressions and body language, and that can lead to more timely prompts or follow-up questions in an interview. And of course, video conferencing technology allows us to conduct focus groups that simply would not otherwise be able to be conducted under the current circumstances. So I've said that there are definitely some advantages to the use of video conferencing, but there are also issues. Of course, privacy and confidentiality is an important ethical issue. If the video conference is recorded, individuals are plainly more easily identified. Additionally, non-research participants not uncommonly walk into the shot. I mean, all of us have had this experience in our own Zoom calls. It's virtually ubiquitous in the Zoom calls that I participate in that at some point, someone will walk into the shot in the background. And so for a variety of reasons then, we only audio record our video calls that are used for interviews and focus groups. And it's just, I think, a good way of avoiding undue problems with added identifiability of participants and also the issue of bystanders sort of walking into the shot. Of course, bystanders can not only walk through the background, they can actually do things like join in the conversation if it sounds particularly interesting. And this may surprise some of you, but that actually happens not infrequently while people are being interviewed. It can happen in person, but it can also happen in the video conference setting. And so if that happens, we simply seek consent from the bystander for their participation in research as well. So I take it that it's just obvious that we all hope that soon we'll be able to transition to a post-COVID world. For me, the really interesting question is whether research will go back to business as usual. And my suspicion is actually not. I think some of the shifts that we've seen towards conducting aspects of research more virtually are going to be enduring after the pandemic. And there's a simple reason for that, I think, and that is that a lot of the changes that we've seen have actually been changes that were sort of in motion for the last 5 or 10 years. And the effect that the pandemic is likely to have, I think, on aspects of research becoming virtual is going to be to accelerate the adoption of those changes. So let me give you some examples. E-consent is something that's been of interest for the last 5 or 10 years, for sure. Prior to the pandemic, only a small percentage of clinical trials used it. In a recent systematic review that we completed of 4,000 pragmatic randomized controlled trials, only 2 to 3% actually used e-consent. But there's no doubt in my mind that post-pandemic, that proportion is going to be a lot higher and continue to increase. The remote delivery of study interventions, I suspect, will also continue to be used. It offers some real advantages, not only in terms of convenience. I mean, it avoids things like travel time and having to wait in a clinic and so on. But importantly, it also extends the reach of interventions geographically, extending the reach of them to rural regions of the country, and ultimately enhancing the generalizability of study findings. Finally, there's been a lot of interest in the use of wearable devices, apps, other forms of patient-reported data. And that's been for at least the last 5 years, particularly with pragmatic trials, but also more broadly, people interested in using real-world data. So I think the continued use and expansion of wearable devices, apps, and other forms of patient-reported data are going to increase sort of after the pandemic. So the post-COVID research world will, I predict, be one in which these moves towards virtual research are adopted even more broadly than we're seeing now. Thanks very much.
Well, fantastic. Thank you, Dr. Weijer, for your very informative presentation. I'm sure we're going to have a lot of questions to discuss. And with that, I invite everybody to turn on their mics if you feel comfortable doing that, unmute yourself, and ask Dr. Weijer some of the questions that you might have. And I will say, I'm going to turn off the recording right now, so this portion is not being recorded.
Thanks, Ben.